Here in the studios, Dr. Yusuf Tanko Sununu is chairman of the House Committee on Healthcare Services, also a former General Secretary of the Nigerian Medical Association. He's serving as a member of the Presidential Committee on Healthcare Reforms. Dr. Sununu, Honorable Sununu, pleasure to have you on Good Morning Nigeria.
Thank you for inviting me.
Also here with us in the studios is Dr. Gafar Alaude. He's an expert in healthcare financing. Pleasure to have you with us on the program this morning.
Thanks for having me.
Okay.
All right, we also have joined us via Zoom Dr. Ibrahim Wada. He's Chief Consultant Gynecologist, founder and chairman of NISA Hospital, and also Chief Executive of Garki Hospital in Abuja. That's a public-private partnership PPP model with the Federal Capital Territory, FCTA. It's a pleasure always to have you with us, Doctor.
Thank you. My pleasure to be with you. Thank you.
All right, gentlemen, once again, I'd delight to have you on the program. Incidentally, we've had a number of attempts in the past towards reforming our health sector, but the fact that we returning to the same subject matter with the new presidential committee would indicate that all is not well just yet with our health sector. So, beginning with Honorable Sununu, are we this time around looking for a silver bullet to fix our healthcare system?
Well, thank you very much. But let me first of all recognize my mentor, my senior colleague, Dr. Wada. It means so much to me, and it means so much to healthcare in Nigeria. A pioneer of a private-public partnership, which is a beginning to set up a reform in the system. And Garki is a very good example of how to move about, and we hope that we get ourselves there. Well, really, if you look at the situation, I think the president needs to be commended. The need for reform cannot come at a better time than now. When you look at the whole situation, the major determining factor as far as all this concerned is COVID-19. It has done so much damage to the economy. It has made a lot of people to be unemployed. It has even gone with a lot of healthcare workers who have sacrificed their lives in an attempt to ensure that the world is protected. So with this, you have to look at it. What are the damages? And the president found that really, when you look at the resiliency of the healthcare system with COVID, it shows that not only in Nigeria, world over, that the resiliency of health system is not as it was thought to be. Because countries like Germany, America, US, and others are all on their knees. And people are now beginning to go back, think inward and out of box to see how we can save the situation. Take, for instance, now, as at 2 years back, if you look at the World Health Organization, in terms of human resource for health, it recommended a doctor for 600 patients. In Nigeria, as Attain, it was one doctor, there's 6,000 population of people. Now, in the last 2-3 months, you've seen the number of healthcare workers that have moved out of country. I was in the Nurses and Midwifery Council of Nigeria, and averagely, almost 1,000 nurses leave per month. In the last 17 years, we lost almost 17,000 nurses to the overseas. So it means that we really have to restructure. We'll have to look at what is making them, despite the fact that we are training them, what can we do to make them stay in the country? And we must also look at how much can we produce to match the exit. Because if you cannot match the exit with inflow, it means you are going to be working at a deficit, and that will not be in the interest of the country. Look at the infrastructure. When pre-COVID, we only have 3 laboratories in the country that can diagnose COVID, molecular laboratory. Even though the COVID has really, we learned a lot of lessons, and the federal government, a partnership between the executive and legislature, was able to produce. So far now, we have more than 150 public-based laboratories. And then we only have fewer than 20 ICUs, but now we are proud to have more than 120. But in all these things, if you look at population versus access, you know that really our population of over 200, or nearly 200 million, cannot be served with only 120 molecular laboratories or isolation centers. It's grossly inadequate. This also necessitates. So we're not looking for a goal this simple. It is necessity. We must do it. And otherwise, we'll be left behind. The health sector reform must be done.
All right. Honorable Sonono, thank you. You've mentioned Dr. Wada, so I'll just take my question to Dr. Wada before we come back to Dr. Laode. Dr. Wada, it's good to see you. And going through my producer script, it's amazing to know that there was a time in this country when Nigeria was a center for medical tourism, when people from other parts of the world come here for medical treatment. I also found it quite interesting, and of course I observed this during the time of Ransom Kuti, when primary health care was flourishing and all of that. And Kingsley asked a question: what exactly are we looking for? Are we looking for something that is new? Are we looking for something that we do not already know? What is it that has been going for you in the Gariki model that would be, not novel in the present health reforms?
Thank you very much. I'm honored to be here, especially honored to share the platform with a great man like Honorable Somuno. The reality of what he has said is the gift of God to Nigeria in terms of human beings is unrivaled anywhere in the world. I'm proud of my country. God bless Nigeria. God bless you, Honorable. God bless the people who are looking after our health care in the Senate, in the executive. Let there be no doubt that Nigeria has the right people. So why are we where we are? Using the statistics he said, people are leaving. We are not able to meet health for all by year 2000. We couldn't meet Millennium Development Goals in health, nor even the Sustainable Development Goals now they don't look like we're going to catch it and be the best in the world in, telling the world that we can do this. However, because we have the right people, because we do have a great country, whether anybody likes to hear that or not, there is extensive hope. Are we looking for something new in trying to establish a new health reform committee to come and tell us how we should go? The answer is absolutely no. Health reforms have started in this country in the 1940s. Can you believe that? Into the 70s under the military and the 80s. And I remember as a child, health for all by year 2000. I remember. So we are not looking for something new. We are looking for renewed vigor in applying what we know, selecting why we made mistakes in the past, why the 1946 reform failed. What about the aim for health insurance right from 1960? Why did it take us 20-something years to put it, or more, actually 40-something years, to be able to actualize it? Why is it limping now? Those are the questions that must be asked from past history to give us a way forward, select the best, what we can do, we can afford, move on with it. Now, talking about public-private partnership, I think every time I raise my arms to the Lord, that he gave me the opportunity and my team to test it on a big scale. A hospital in Nigeria that was it was already crashed. So it was not open to the public at all after just being run for 20 years under the public sector system. We woke this place up with dedication, with commitment, with investment, with clear leadership policies. And that place is looking up now. It's a place of beehive of activities. It's a place of some level of confidence by the population. I don't want to go into the politics of it, but I pray every day that we should remove politics and sentiment from our health. A man being sick understands everything must be done to bring him to health. A man dying loses everything. So we cannot afford to see a working example like Garki Hospital and just wrap it up, baby bathwater, off you go. We are back to 1980 again. We couldn't do year 2000. And again, we are trying PPP, or it doesn't work. Why must be the message of Nigeria be it doesn't work when we have the best people? So I want to define where we are and what we expect. One is that the word public-private partnership has 3 Ps, but the word healthcare also has 3 Ps. What does that mean? Who are the people you are designing the healthcare for? P. Who is going to provide that healthcare? P again. Who's going to pay if that healthcare is given? Another P. Until and unless we get that right, again, we are doing. Because even in the traditional healthcare system, we did give them chicken, we did bring our goats, we brought yams. That's what's paying. Doesn't have to be naira. So what am I about to say? You mentioned the late Professor Ransom Kuti of blessed memory. May God put his soul in the best part of paradise. A true Nigerian, an example of we have the people. How many people do we have? Hundreds of millions. When they wake up, where do they say, I'm not feeling well? It's not going to be 20 kilometers away. It's got to be somewhere near where they live. Who has the knowledge to decipher? This is a serious thing, therefore go here or go there, or you can be treated locally. I'm talking of primary health care. And I think any reform that says who is the citizen, who is the beneficiary of this health care, where does he live, where can he go if he has a headache or a sore thumb? Those things, once they're addressed, leave it to Nigerians. They can go to the moon from there. Thank you very much for the opportunity.
All right. Thank you very much, Dr. Ibrahim Wada, there for your opening salvo. We'll return to you in the course of the conversation. Back to the studios, Dr. Gafar Alawode. What are we trying to fix in our health care system?
Okay, thank you very much. And once again, thanks for having me. I think before we go to that specific question, let's try as much as possible go the memory lane in terms of successful reforms in the healthcare system all over the world. And when I think of that, when I discovered that the Mr. President is setting up a committee, I was elated. Elated in the sense that probably the most well-established, well-studied health reform in the world is the UK system, which started, the reform started during the Second World War. And as a response to the hardship that people were feeling there, then the Labour Party then in 1941 decided to set up a committee, similar to what Mr. President is setting up, to look at how do we reduce the hardship, how do we expand social health insurance coverage generally, which would include health. They did the report, and the Popular Beverage Report came out in 1942, which recommended establishing the National Health Service in the UK, which essentially established the institutional and financing framework for health, which would make health, everybody to be able to have access to the health care. And after then, there have been similar examples, and in Turkey, the reform started with similar exercise, and then in India and many other countries. What is the commonality here? The process started in those countries as a political process, not just technical process, where we have the political leader trying to define the reform, the change they want to see in the health. Don't let us forget that policy is essentially politics. If you remove politics from policy, you are left with just policy documents, which will not fly. So we need to get that clear and see the opportunity in the ongoing process. Very, very important, because most of the countries in the world, the process started like this. But it's not automatic that when you set up a presidential committee or high-power committee that they will deliver. What have we learned in the past? In most cases, when you set up a committee like this, usually the focus usually heavy on the content of reform rather than the context and the process of translating the content of the reform into the action. And you see a lot of discussion and like Dr. Wada, a very senior, I really referred colleague said, probably a lot of things that we need to do we already know. So if we now focus on what do we need to do, what do we need to do, put it in the document, you discover it's not likely to fly. As we are looking at the content in terms of reform, the financing, reform the human resource for health, reform institutional and everything, we should be looking at what are those processes and what are the bottleneck, what are the impediments to the previous attempts, and what do we need to do differently this time around. But coming to the content now, of course, we have to get the content right as well. We need to reform, first and foremost, financing landscape is essential. It's part of the P that Dr. Wada mentioned. Somebody has to pay. Anywhere in the world, somebody has to pay for any form of service, including healthcare service. So what do we need to reform in the financing landscape? One, we have to look inward and see from both public and private investment and everything, what do we need to do to improve investment in the healthcare? Analysis have shown, studies have shown that a country that are spending below certain benchmark, which were a lot of them, they will not be able to expand healthcare access to the teeming population. So funding is very, very important in terms of money coming from government and money coming from other aspects as well. But it's not only about the volume of resources alone. The efficiency of spending in terms of and spending in Naira on healthcare, what amount of help should I get from that 1 Naira? If I'm getting below it, who is asking question and who is taking necessary action? It's very important. Number two, there are a lot of things we can say about financing, but number two is the institutional arrangement and capacity. You cannot have an 18th century institution and you expect it to deliver on the 21st century development agenda. We need to look inward, reposition our institution to make them more effective and able to deliver on policy. When Honorable Sunono committee finished with their work, it is not Honorable Sunono that is going to implement. It is still going to be the ministry, department, and agencies that are going to implement this. So we have to see how do we have 21st century institution. Of course, we are not saying something will change overnight, but as part of the process of implementing whatever they are coming up with, process of institutional repositioning has to be very, very clear. Number three is our accountability framework. In terms of who is asking question for the billions and billions at the national level and subnational level that we are spending on health. Who is asking the question? What indicators are we looking at? What is the platform for asking the question? But in terms of the content as well, while I agree with Dr. Wada that there are many new things, but there are still some new things we have to look into. We've been talking about human resource for health. People are going to the UK, going to Saudi and everything like that. The simple truth is that does Nigerian government, looking at the budget today, able to absorb all medical graduates? The answer is no. But Kenya is doing something very, very important, which they launched just a couple of months ago. They established a relationship with the United Kingdom and said the excess health workers and other countries are doing, the Philippines and others, the excess health workers that we are not able to absorb now, maybe we'll be able to absorb them tomorrow. But can we enter into a relationship with you where you help us train them further and there's some economic benefit for us? Don't let us forget. Doctors, you don't know Dr. Wada and myself that are medical graduates that went to the maybe public university. It was Nigerian government that paid our tuition. So if Nigerian government pay the tuition for medical students and they graduate and they go abroad without plan for coming back, or Nigerian government, what has Nigerian government gotten with it? So those are part of the new things we have to incorporate to the reform. Agree. Bulk of what we did we already know, but at the same time, it has to be evidence-driven. We have to look at what is happening elsewhere as well and see what we can do differently. I would like to stop here for now.
Yes, Dr. Alaude, thank you. But do you see a gap in all of the items that you have enumerated as issues to be, looked at in the reforms? Do you see a gap in the previous reforms that has, made them ineffective, that have rendered them ineffective? And I'm looking at it from the point of view of contextualizing the needs, the health needs and behavior of Nigerians, which should drive the reforms in the first place. Is that a gap there?
Absolutely, absolutely. There are a number of gaps. Number one gap that is very obvious from previous attempts. Probably the previous attempt did not actually reflect the context of the country, especially the federal context of Nigeria. Nigeria is different from Rwanda, Ghana, and many other countries that people turn to Mecca to go and study our reforms. Nigeria political system is more complex. We have a federal system, and we have different tiers of government that have constitutional responsibility to make policy and implement policy. And any attempt to reform without taking into consideration, thank God, Mr. President, in this new committee, we have a governor there, but that's not enough. The Nigerian Governors Forum is a very, very important stakeholder when they are talking about policy reform in this. And we've seen a lot of reform. When we finish, the governor said, we don't know about these things. And we, in the recommendation, we want the state to do this, and this. That is number one, not reflecting the context. Another important factor that you mentioned in terms of the health-seeking behavior and all this.
Yes, and their needs.
And their needs. What are we seeing from even the basic care provision for the newest policy instrument to repositioning the health financing landscape? If you look at most of the facilities now, money is going there, but people are registered. But are they coming to access the care, despite the fact that, okay, we've taken care of the money for you and everything like that? What is missing? Effective community engagement, citizen engagement, looking at existing structure. And that is where strengthening the system is very, very important. Most of these things we have, like, for example, NPAC, they have the community structure and all those stuff. But when we are looking at reform, we don't look at holistic reform. When we want to reform the finance, we look at only the finance, we look without looking at the community aspect. So you solve the finance problem, and the people in the community are not accessing.
You made the same mistake even when you were reading out the areas to be reformed. You left a gap.
Well, there is no way I will be able to say everything.
Dr. Gafar,
yes.
Thanks. Honorable Sonuno, I want to skip you in the meantime and go to Dr. Ibrahim Wada. On the basis of his current experience and the historical background he provided to healthcare reforms in the country, dating now well over 80 years. Dr. Wada, one of the issues that we have often taken on Good Morning Nigeria, particularly in recent times, has to do with the gap we find in our public policy ecosystem. The difference between a blueprint and then the outcomes, and that whole process of implementation. Why is it that reforms that are enunciated, when you see the blueprint, you say these are the recommendations of the committee, Honorable Sununu and his members, they have worked, this is the report, everybody will praise it, then it starts to roll. A few months down the line, a few years down the line, everything packs up. Okay. You have the entire landscape is littered with countless examples. I mean, just to say, this is by the way, Niger Delta has a development master plan designed by the NDDC. As we are talking, I don't know where that plan is, and nobody in Niger Delta knows what that outcome has been. In terms of our healthcare reforms, is it advisable, therefore, to just say, look, what were the salient issues in each of the earlier reforms? Why did they fail at the point of implementation? And then get the committee to focus on those implementation challenges.
I think we've suffered over many years in all sectors about plan not being actualized. Part of it is that a lot of those plans are on the pillars of bureaucracy. And those bureaucratic principles rest on government. For long, Nigeria suffered repeated changes of government. Now we are lucky, we are fortunate, and that's the real area of hope, that the democratic experiment that was birthed in 1999 seems to be sustaining, seems to be solid. No matter the difficulties, if there's stability at that level, then people can expect. Unfortunately, the other era, you didn't know who was coming as the next leader and what sort of means. So now there is hope, and may God protect the democratic credentials of our country. Now, the other reason that we could plan and it doesn't work, of course, every government that has come into our lives since 1966 or even before, they are tackling corruption, and all that. So we cannot rule that out. Is it something that we must tackle head on, almost like a boxing match? If it was that simple, by now it would be history, because I don't see any government that has come into this country, whether democratic or non-democratic, that didn't put corruption in their rifle sights, trying to fire it. We must find a different way. We must use what we've got to get what we need. And what we need is human life in terms of health reforms, avoidance of diseases, prevention, treatment, prolonging life, so we too can live in God's earth as long as other human beings, because we are dying too early, we are sick too often, and that's not acceptable. So we must then either protect our health reforms against the wave of corruptions and all that, or find a way, use what we've got to get what we need. Life is the ultimate, and I would pray that a time comes when every other thing could be touched, maybe not, but health is sacred. It's God's own domain. He created us. He gave us this land we are living in, and we have a duty to him to prolong it and to make it more useful. The third element is funding our wishes. You see, when they issued out Garki General Hospital as a public-private partnership, government made it clear, we don't have a penny to put in this. You fix the place, you employ the staff, you equip, so help you God. That was the message to the organization. And because Nigerians can do magic, and I keep using that word, with very meager resources, management, efficiency, forward planning, stability, look at what has become of Garki now. So the public sector funding has so many branches, so many rules, so many this. So to even access a little bit of money, the paperwork is more expensive than the financial implications. So what's going on is we make a plan, but we are hampered in funding it. In the public-private system, you make a plan, so help you God, and the people come and then they have confidence in what you're doing. They're going to partner with you, and I mean financially, to achieve set goals. And that has been demonstrated. So in terms of health reform, the National Health Insurance Scheme, NHIS, the public-private partnership policy, they will survive if there is a will. How come it's only Garki that everybody is talking about almost 14 years into the game? We must losing Nigeria's potential to help herself. We mustn't say, if government cannot afford, then let us all perish. Let's be sick. Let's die early. Let our mothers die in childbirth. Let children not make it to 5 years of age. We can't say that. Nigerians are human beings. They can help themselves in certain cases. Where they need help, then the government can come. So if our health reforms will ever make it, it must be freed somehow from the governmental cash-strapped situation. Cash-strapped in a sense that they are funding security, they are funding transportation, all sorts of things. So what do we excuse out of the whole game and let the people help themselves? Healthcare, because that's all they've got, their lives. I want to stop at this stage by mentioning those three things. Policies can become actions, provided we take some of the precautions that I've said. Stable government, less bureaucracy, allowing our people to contribute their own quota of funding to actualizing what would benefit them, and that's it. Thank you.
Dr. Ibrahim Wada, I'll still stay with you before we come back to the honorable member here in the studio with us. Indeed, Garki is a success story comparatively, but I don't know if most public patients or paying patients would actually describe it as a symbol of international best practices. But regardless, the Garki model, if replicated across board, do you think it will engender universal coverage of quality health care, access to quality health care?
Thank you. That's a very important question. You see, for a model to be perfect, all stakeholders must buy into it, must believe in it. We must first believe that only us can make the difference that we want in our own lives. Some people say, oh, can the people afford it? Is it accessible? The answer to that question is not wealth to access health. It is the national health insurance. As it is today, you cannot even, you pay, what they pay to the hospitals is probably $1 plus something, 750 naira per head, which has no bearing with today's economy. But you can't get that anywhere in the world, even in the poorest places. Yet, we are not able to expand it. If we expanded it, then nobody needs to come to Garki and bring out his checkbook or cash, because there's a framework of access. And that's how the world has gotten by it. So it can never be too expensive for Nigerians, provided that side that bureaucracy provides, the access side. Pay a little bit of money every month, anytime you are sick, no matter how expensive that sickness is going to be to treat, you get access, because we are all our brother's keepers. Everybody's chipping in a little every month to make sure that anyone in the community that falls foul of his health is helped. So I can tell you that is a missing link, although at the moment, more than 60% of people that are using Garki, they don't pay out of pocket. Majority are NHIS, some are from private organizations who are paying for them. So if you come closer, you have a model here that you can sit and say, let us dissect its strengths and its weaknesses. If all stakeholders had come together believing in the PPP, believe me, by now, most of the hospitals will be on that note for efficiency and competition, and people will be able to walk in and walk out like they do in England. And I remind people, if for 1 second anybody in England has to pay for his health care, or in America for that matter, nobody will go to their hospitals. They are too expensive. Or Germany, or anywhere in the world. The reason why they are going is because there's contributory health insurance. And I thank my brother, my friend, Dr. Sununu, and his colleagues in the National Assembly, when they said that all Nigerians should be mandatorily covered by health insurance. That is our first step in the journey towards universal health coverage. Like anybody can do it, I am saying Nigeria has the people and the financial wherewithal to do it. But we must separate all those three things I've told you, believe we can, and let's get on with it. And it is not just government that can take us there. So I think I can leave it at that point, that Garki should be studied. It should not be wrapped and thrown, and then our 15 years or so of our history buried. We start all over again. Why? So I think I can leave my point on that emotional note. All the work that more than 600 Nigerians have been doing every day, every month for the last 14, 15 years, you can't just wish it away and say, oh, it's not working. You should ask yourself, what can I do to perfect it? And get on with that. Thank you.
Thank you very much, Dr. Ibrahim Wada. Let's come back to Dr. Sununu, who's a member of the Presidential Committee on Health Sector Reform. Dr. Sununu, what is the critical focus of the committee? What is it looking at? Is it broad spectrum, or there are specific targets that you are aiming at?
Well, thank you very much. I think I wanted to respond to some of the issues discussed prior to now. So that
fantastic. That's
good on that.
Very well.
Yes. If you look at the issue of reforms in the country, I think we started getting it wrong when we emphasize more on curative services rather than preventing services. If you look at all the previous reforms until now, most of the reforms are on curative care. And that's why so much billions were spent in trying to build mega hospitals
Exactly.
in the country. And that doesn't really work much. For example, now, let's say the primary health system. If you have there is no way you can have the confidence to go to a hospital where you are sure that the human resource for health there may not satisfy your need. The infrastructure there is an ISO. The access to even basic drugs that you can be treated may not even be there. And that's why you see, if you want to get it this thing, that's why if you look at the concept, is to have a holistic approach. So that I quite agree with all the previous speakers that we need to go back and find why can't it work? Why doesn't it work? And how can we now make it to work? And I think that's the essence of this. If you look at what we have now, instead of having a normal pyramid, we have an inverted pyramid. The pyramid in treatment of diseases should be stepping up so that at the base you have more people covered. Precisely. It means the primary health centers are functional, people are satisfied. Precisely. And then you have the peak at the teaching hospital so they can be for training, for high ceiling researches, and whatever you think, for multi-centered control trials so that more money can come in terms of grants. Because even only for grants in medical practice can be able to sustain healthcare services. How many billions of naira are we attracting in the country? It is just a recent. Our NAFDAC, that is supposed to be the regulatory body, was initially just at level 1. It's now that we are working, we have reached level 2. We have applied for the World Health Organization has just came in and assessed NAFDAC for level 3 to give it the ability to be able to supervise randomized controlled trials, so many researches in drug and drug development. So you understand, it's only when we move like that, we now try to reverse the inverted pyramid. Now, if you look at that's one aspect. Now, if you look at the preventive aspect of it, most of Nigerian diseases, as today, yes, we are having emerging diseases that are coming, but are vaccine preventables. Where are we as far as vaccine production? Senegal here can produce vaccine. Where are we? So if we want to reform, we must focus on the body. Why is the body? The body is more or less on infectious diseases. Now, this is just Nigeria, the World Health Organization has approved vaccine for malaria. Are we ready? Can we produce it locally? Can we even have the technology to invite those who have licenses to come and have a branch and produce it locally to reduce the cost of transporting and other things? These are all issues. Look at the COVID vaccine. How much does it take in terms of logistics for a cold chain to be maintained from the source to Nigeria and to the person where you are going to administer? That is enough to produce the vaccine if you have it in the country. So these are the issues that we must do. We must be sure that we look at our manufacturing sector so that we can give them the necessary impetus to do what they are supposed to do, and this country move forward. Not only that, if you, he has also talked about the funding. The funding. Just like people used to say politics is local, health is also local. Are our local government ready to even serve as a distinct? Do they have the will? Do they have the autonomy to employ? Do they have the money to recruit and then distinct? It's just a reason that even if you look at even the other issue is the confusion in terms of the status of health in our country. Health, as important as it is, look at the Constitution. How many times is health mentioned? It's never in the. It's in the. If you look at the health provision in the Constitution, you will really be worried. Are we there? Are we there, and are we getting it there? So if we cannot make a strong statement in the Constitution to say that, look, health care delivery in the country must be a universal human right in Nigeria. And then that's now when people now begin to work to meet that demand. And that's why even as us as legislators, we have the opportunity to amend the National Health Act, National Health Insurance Scheme Act. And what is the basic gap there? We keep on saying National Health Insurance Scheme did not cover everybody. When the legal framework that establishes the act did not give it the policy or the position or the ability to cover everybody. By the time they attempted to do that, they are also going out of the act, and it's a breach of the act. And that's why we say, okay, let's look at the act and make it mandatory. If you give them mandatory status, then every Nigerian will have right to have a basic minimum package of health. And that is now a fundamental human right. Now, if you have that basic minimum package, it's not only to set it, how do you now fund the package? And that's where people like Dr. Gafar, who are experts, came in. And they advised us to areas that we are going to look forward. And those areas we have looked and addressed them and put them into National Health Care Insurance Scheme, so that I cannot give you responsibility without giving you a means of funding. It means I have a plan to fill ab initio. And I think we have finished our work as National Assembly, and it is now with the executive. And we do hope that Mr. President will assent to it. And once that is done, now we have hospital replicated. That will be replicated like Garki. For example, now, any hospital, I'm telling you, any hospital that enroll or participate in National Health Insurance Scheme and have less than 10,000 enrollee, that hospital is likely to crash in the next 6 months or in the next few months come, because most of their resources will be going in delivering services without our distance. But when you have over 200 people in 200 million people, Nigerians, are now covered. Okay, let's say it's still 760. Now, when it terms that 760 capitation by 200 million, it translates into large sum of amount. So why are we not moving forward? Because very few people are covered, less than 5% of the population.
Are you likely to effect any reform in the per head cost for NHIS?
That one doesn't need to even be it doesn't need presidential reform. The Act has mandated them. They have given the policy. The Act did not say that charge 760. No. With time, you have subcommittee to review the implementation and find bottlenecks so that they can now develop their policy document. Act cannot cover everything. It must give a room on which for the organization to develop a policy. And that's why a lot of this, they have what they call, some they call it guideline, some will call it framework, so that they can develop. That guideline can now be changed. If in the guideline say that everybody should be covered by 760, the guideline over 5 years can be reviewed. And nothing will say that no, 560, even what it can, there is no way it can cover anybody. Okay, say yes, we can leave it, but let's expand our coverage to 50% of Nigerians. Now more money is available to the system.
Dr. Sonono,
Yes.
Let's return essentially to the focal issues around the health sector reform.
Yeah.
You're talking about healthcare insurance, which is fine. So the patient goes to the hospital. There are a number of issues that will arise. One, that's why I'm saying, what is the focus? Are we also looking at our pharma security? That's to say, pharmaceutical security. Because that's a key point that has arisen. You talked about vaccines already, but a broad range of medicines are imported into this country. Two, equipment and facilities.
Yes, I'm coming to that. You see, if we are going to have a focus, everybody knows we have what we call pillars of health. And once those pillars are not erected firmly, definitely whatever you go, it will collapse. The reform must look at must put emphasis and focus on human resource for health. And this is one of the most vital aspects of the health that we must look at. It's not the gadget you have. We have so many equipments here, you understand? But put the best equipment and then put somebody in your position who is not trained. Nigerians will not be satisfied to look at, to watch NTA. You understand? So have a gadget, and that's why we go and import so many gadgets without even training those who will man the distance. So we have to look at the human resource for health. We have also look at the healthcare delivery chains in terms of the primary health centers, the secondary tertiary institution, and the teaching hospital we have. For example, nothing stops our teaching hospital to be comparable in terms of hygiene, comfortability with Transcorp Hilton Hotel. So that we can have an amenity that people can even go there and while away their time when they are tense enough. You understand? But you have come to a hospital where it is an ISO. Cleanliness is not optimal. Definitely, you have confidence to go there. So we have to look at all the delivery system. Let's make the hospital as our own friendly as possible in terms of the nature of the infrastructure and this. And also we have to talk of funding. The funding is where we are lagging seriously back. People thought, you talk of Rwanda and other countries that have gone far. What measures have they taken? They were in Nigeria. We had Abuja declaration that says give at least 15% of consolidated revenue fund to healthcare delivery system in every country of Africa. And what is the reason? African government realized that they are getting back. The mortality and what have you is not improved. Indices is always getting back. So they now came to have an Abuja declaration. And as far as we are concerned now, even this year's budget is probably around 4.3%, I think, of the consolidated revenue fund. So it means we have a long way to go. And funding is the most vital aspect. If you don't have fund, definitely have all the structures you have. You cannot pay staff. And then you may have a lot of incessant strike. People will come and disrupt the services. And that's this thing. So we also must look at the leadership framework and healthcare delivery.
Yes. Go ahead, Cicely. I have a question for him before we go on break.
Yeah, you popped the question. I will reserve my question until we come back from the break. Because we keep talking about funding as a challenge. And this question is going to Dr. Gafar. You can incubate the question. Do we actually even have value for money from what we are either budgeting at the moment at all levels? Do we have value? Are we spending the money right?
Please incubate the questions. Yes, let's go for a short break. When we come back, we'll now take the answers.
Engineer and project supervisor of the second Niger Bridge project. The second Niger Bridge project is a project that has been conceived for a very long time, but it has finally come to life during this present administration. This project has a lot of socio-economic benefits, and it has impacted positively on the lives of the host communities, both in Anambra State and Delta State. The people are very happy. The host communities, they partnered with us because apart from the social benefits, indigenes are also employed on this project. We can see how their lives are being improved.
This message is from the Federal Ministry of Information and Culture.
Dear customer, link your Airtel number to your national identification number today. Here are easy ways you can do it. Dial *121*1# on your Airtel line and follow the prompts on the screen. Type in your 11-digit government-approved NIN number. You will receive a confirmation message to confirm your entry. You can also visit www.airtel.com.ng/NIN to link your phone number to your NIN. If you do not know your NIN, simply dial *346# to get it. No stress, no wahala.
Airtel, the smartphone network. A new edition of TV Guide is out exclusively with Governor Simon Lalong of Plateau State.
Since assuming office, our rescue administration has pursued the path of peace and reconciliation and restored confidence among people of different ethnic, religious, and political persuasions. Peace is back on the plateau. We are building world-class infrastructure in roads and opening up opportunities for innovation.
The edition is a compendium of mind-blowing stories for your reading pleasure, ranging from entertainment, economy, sports, media, politics, family, and lots more. Pick up a copy and keep abreast with issues and trending features within our space. TV Guide, very incisive, very educative and compelling. Grab a copy at the vendor near you or any NTA station nationwide. TV Guide, your indispensable companion.
Dear compatriots, our country can be as great as we want.
Let us all commit ourselves to its greatness.
We must be willing to set aside our differences, unite and stay as one.
In our expansive landmass, human and material resources, and plurality lies our strength.
Let our challenges lead us to rediscover our common ground, and together, let's find solutions.
This will take some time, so it requires patience, tolerance, and forgiveness from every one of us.
Let all hands come on deck to protect and transform our country.
Let us unite and see each other not as adversaries, but as brothers and sisters.
Together, we can build a better Nigeria for ourselves and for the next generations.
This message is brought to you by the National Orientation Agency, NOA, with support from Nigerian Television Authority, NTA.
Manchester City return from the international break with a tricky tie against Burnley at the Etihad Stadium. Will they get their desired victory? Find out this Saturday when Manchester City take on Burnley on the Premier League Live, showing on the network service of the NTA from 2:30 p.m. The Premier League Live is brought to you by Baba Ijebu and powered by Integral.
I wish you could listen into our conversations in the background with the honorable member. Quite interesting. But this is Good Morning Nigeria. Welcome back. And our conversation is on the, healthcare reform that was instituted by the president a month ago. And we have our guests all seated here. Let me take the question to Dr. Gafar Lawode. Kingsley put some questions to you before and asked you to incubate them. So now.
Okay, thank you very much. I think the questions around value for money or efficiency, that's the elephant in the room. It's a very big one. I think if you ask me, I'll say we are not very efficient. And this is backed by a lot of studies that have looked at how efficient is Nigerian system. And I'll give you some practical examples. In a particular state, we look at spending on the workforce in a particular state in Nigeria. Over a period of 6 years, expenditure on personnel grew from 1.2 billion to 7 billion within 6 years. But that's not the most shocking aspect of it. During this period, there was an embargo on recruitment. And the question is that who is getting the money? You understand? And when we try to analyze, we saw a lot of interesting things happening. Secondly, there's a multi-country study around productivity, efficiency, and competence of workforce, which have huge bearing on value for money and efficiency. Because if you look at the typical state in Nigeria, they spend 80% of their health budget on workforce. So what are we seeing? In Nigeria, Nigerian health workers, and I'm not saying only doctor, nurse, across the cadre of the workforce. Nigerian health workers see average of 5 patients in a day. In Tanzania, they see 15. And the diagnostic accuracy, in terms of if I go to the clinic and they say I have malaria, only 4 out of 10 cases are accurate. And when the diagnoses are not accurate, I'm bound to get wrong treatment. That means whatever I might have spent is wasted. Understand? So, and if you look at other countries like Kenya and every diagnostic accuracy is as high as 70%. But what's the fundamental issue? What drives value for money and efficiency? The way you arrange your payments, what you spend on health, how you spend the money, determine whether or not you are going to get value for the money. Let me give you an example outside the health sector. If I'm paying bricklayers for a number of days they work, they can just go to the site and sleep off. But if I'm paying them based on number of bricks they assemble,
on coaches that they are able to flex.
Absolutely. I'm going to get more value for the money. So in financing balance, that's what they call passive purchasing. You are just throwing the money to the system without looking at what the system is buying or producing. But one of the fundamental shifts I would like to see in Dr. Sununu committee is presidential committee. Shift from passive purchasing to active one, where the money that we are having, we are using it to buy results in terms of quantity of services and quality of services as well. And that is why the issue of health insurance is very, very important. Anywhere in the world, health insurance is a strong vehicle for strategic purchasing, where they have the pool of funds and they say, before we pay you provider for this, we want to be sure that you have provided the services, it's of good quality, you are not necessarily using technology and drugs that are not necessary. And that is why part of the reform, we are making progress on NHS, but we need to do more. And part of what Honorable is saying that we need to pay attention is, if you look at the NHS, a lot of beneficiary or enrollees will continue to complain. Because what is the funding volume? What is the amount of pool fund that is available to NHIS to buy services? Most of the people that are NHIS now, they are former sector people. And it is only government component of money that is being remitted to NHIS. So NHIS is constrained. So we have to look at what is their possible additional way of mobilizing resources. There are a lot of things on the table before the legislature and everything in terms of where additional money will come from. But I agree with you. It's not only looking about more money for health, but we should be looking at the more health for the money as well. We should be able to raise the accountability bar while people are asking questions. And the people media like you have very, very important role to play in terms of looking at indices and putting it side by side. There's a lot of investment that we are doing. I think raising the accountability bar and changing the funding architecture very, very crucial.
Okay, let's get some ideas from Dr. Ibrahim Wada. Again, would always refer to Garki because it is a model. And even there, we see beneficiaries or enrollees, for the NHIS having separate sections where they access their drugs and, of course, services and all that. Dr. Wada, is there a way to attain equity in NHIS services? In healthcare services, irrespective of whether you are an NHIS enrollee or out-of-pocket payee?
Yes, thank you so much for this question. I want to appreciate the Honorable Sununu and Dr. Jafar. Their contributions show you excellence, and that's what Nigeria is all about. Can we have equity, healthcare access, quality, and all that under the NHIS scheme? There are issues. One of the key issues is the amount relative to the true values in the economy. For example, how much are you paying for electricity, staff, salaries, and so on? How does that relate with what NHS is putting on the table? And that must be addressed, because you can't continue to rob Peter to pay Paul and the whole system will not crash. So, but even be that as it may, the truth is there's a log jam somewhere for long, whereby the intermediaries, the HMOs, yes, they do a good job to verify the reality of what is being claimed before paying, but many of the hospitals in the scheme, they don't have access to this money until a long period after, and even then, other issues creep in. So there's a lot of adjustments that are still needed, which will bring respect and equity, because that is it. You come to access healthcare in a secondary or even primary health center, and they've not been paid for 3 months or 6 months. Even these mega sums we are saying. What do you think the attitude of the people who are delivering these services will be to you? So, but these are not insurmountable problems. They can be confronted head on, and we can get there. Having said that, I've been burning to make a contribution about the people themselves. Like I said, there's 3 Ps: the patients or the people, the payers, and the providers. When Honorable Sununu mentioned the preventive and community health, we are weak on that. Primary healthcare, which is actually the healthcare of the people, for the people, if you like, that one also we are weak on that. And if we can pay good attention to those levels of healthcare, to be sure that you are seen early in disease without any fear of money, to be seen that your water, your environment, the air pollution, whatever gives you a healthier life without falling foul of disease. If those ones can be attacked head on with the resources we have, places like Garki, other private providers, even governmental providers, will now be able to focus specifically on their motto, on their agenda, not this kind of you think you have typhoid and you end up in Garki direct. It's not necessary. You go to a primary health care, they will make the clear diagnosis. They might treat you. If it becomes impossible for them to handle, then there's a referral system that takes you honorably to some other secondary or tertiary center. Unless and until we place value on human life and the people to the extent I've described, the chaos and confusion will lead to waste, leakages, and lack of good productivity within the system. So I have to add that Garki has to see typhoid, has to see malaria. So does National Hospital. They waste a lot of energy and strength at that level that should have been sorted very close to where the individual lives, with environmental sanitation and protection that would have prevented a lot of those so-called malaria, so-called typhoid misdiagnosis or diagnosis. So I hope this kind of contribution will help those who are in the committee, that what can government afford? Is it primary care? Is it community and preventive health? Let us put every effort of government to make sure that everyone has a place of call when they are sick without the financial implications. The rest of it, secondary, tertiary, gradually we must get it right. Thank you.
Dr. Wada, thank you very much, but I still want to stay with you for this point. The argument has been very well articulated with regard to what we need to do and about preventive healthcare and whose responsibility that ordinarily should be. If we had an efficient local government system, that's one area they could easily take care of. So the politics of it is important. That's the context that Dr. Gafar also mentioned. But we have seen for several decades running now a rise in private healthcare delivery system, such as we have also seen a rise of the private sector in our educational system. And to the extent that even from anecdotal evidence that we don't quite get full value for budgetary allocations on health at all levels of government. Could it be, I'm just wondering, Dr. Wada, whether it's a PPP arrangement or otherwise, you mentioned a moment ago in terms of takeoff of Garki Hospital, government says we're not putting a penny there, you know, go fund yourself, go run it. Could we probably tinker with something and say, look, there are lots of inefficiencies in our healthcare spending. Sometimes you find some of the luxury vehicles that ordinarily you'll be finding with CEOs of blue chip companies elsewhere in the world. That's what they are using as their project vehicles and so on and so forth. Could government then say, if I say I'm referring to government at all levels, say we would allocate a certain percentage of our resources, target certain hospitals, and there are top range private hospitals in Abuja here. I've seen them and say, look, as part of our equity stake, this money we're going to invest in equipment. All this money we're going to invest, in you hiring top grade staff. So that becomes your equity stake, in which case that organization should be corporatized. You have to have a board, you have to run it efficiently, so that government's money goes in there. As I said, primary healthcare you've already taken up, but for you to get value for your money, private sector is doing well, and Nigerians, of course, like good things. If they know that your hospital is good, they will come there.
They will come there.
Dr. Wada.
Thank you so much for this. I wish you were a member of that committee, in all honesty. You see, let me probably just say that since 1980, I've been in the government system in Jos, went abroad, came back to the government system at Gwagwalada, and then the National Hospital. So I know where the holes are, where the wastes are. And until and unless we take health as a public and private enterprise, entity, we are just still beating about the bush. You see, let me give you an example. The United Kingdom government sends patients to India for treatment with government money, where they feel that they cannot cope with the numbers. That's not to even talk about France, or the United States has partnerships with Singapore, which allow certain patients to go there, get treated in world-class facilities and back. We cannot afford not to throw both private and public resources at our lives and at our health. We may not do that for every facet, but for health, I plead with the Health Reform Committee people that this life belongs to God Almighty. It is not about public or private. Whatever mix can protect that life, we must adopt it. Garki was a press button fast forward development, to be honest. Before we could say Jack Robinson, Garki was able to offer the kind of services that our teaching hospitals were struggling. We got MRI in, we got CT in, we're looking at heart surgery, kidney, all sorts. And I can tell you, even the accessibility to such high-level services under that kind of public-private umbrella with government stakeholders interested, if they were, the people can walk in and get treated and live longer lives. So you are absolutely right in saying, can government partner with private on a more deliberate way, use their human, material, and other resources to provide services beyond primary care that will prolong life and help people? The answer is absolutely yes. And that time has come. Can government, like during the PTF era, when they will, the drugs that hospitals needed, they will import in large scale and distribute to public hospitals and so on. That time has come. Can the manufacturing arm be a government-private enterprise so that what Nigerians need is not left to, we will import, we will keep importing? These are the things that I think the reform committee must put on their table, is our health, the people. And it is whether they are accessing that health by private alone, government-private marriage, all towards one purpose, so be it. I want to emphasize that the primary level where people must not be denied help when they need, that primary level must be free of encumbrance. We started it in the 80s under Ransom Kuti. We need to go back to that stage where every household knows their hospital address. Government knows about them. We know the prevalence of disease in that community and what to do to give them a healthier life. Let us not be afraid, dear committee members, to revisit our past and extract what is so positive and blow it now. I will end this segment of comments by saying, you know what? The population of Nigeria is increasing by country levels every year. I mean, you're talking 4 million Nigerians being added. So while you and I are talking, there are more mouths to feed health-wise. So it's not a static equation where we can say, oh, next year we'll do it. 2 years, we will do it. Get on with it. Press the fast-forward button and let us get on. Private, public, public-private partnership. Whatever we can throw at it to achieve a fast-forward. Thank you very much.
Ibrahim Wada, thank you. I just like to, we just have less than 2 minutes, so we're going to share the 2 minutes between Dr. Laode and Honorable Sonono. But Honorable Sonono, to address the low-hanging issues that tend to pull Gariki down and, overshadow its successes, why don't we just do away with this co-joined model, PPP or whatever? Why not an outright user fee, model?
Well, we could have gone like that, but we have to also look at the health itself as not only business venture. We have to know that it's also welfare services. That component must be addressed. The component that not every Nigerian can just put hand out of pocket and then pay. So we must give security coverage to those who cannot afford. You understand? And when we do that, you now say, okay, we have. You see, the whole issue is what we have been saying, lack of standard services at lowest level. I'm sure if you are comfortable, you can get the desired satisfaction in the primary centers next to your door. You don't waste your time to travel to this thing.
The ones in my place don't even have, they use candle at night when
this is what I'm saying. Now, so this is where we are now going to pay attention and improve on it so that we can reduce the burden up there. And if we didn't do that, we are really still getting it wrong.
Dr. Laode.
Okay, thank you very much. Before going to that specific question, that was a very, very important point that you raised around equity financing. Of course, part of what people are looking at and generate a huge investment for health is private equity investment. Where from private equity investment, people invest in health facilities. And when they invest in health facilities, it's not only about money, technical know-how, transfer of technical know-how to the management of the facility. Now, approximately Nigerians spend $1 billion going to India, UK, and everything to treat them. So, like 4 categories of conditions. If we invest in the through private equity, for instance, in addition to other sources of funding, it can reposition our tertiary care. And a lot of foreign exchange we are talking about, we can actually capture them locally. Then coming to the question, please, the focus of the health policy in Nigeria and many other countries is universal coverage. And there's no way, if we depend on the user fee, people paying out of pocket, to not take us there. I think our reform, the presidential reform, should be looking at what will put us on the trajectory of the universal coverage. And one thing is very, very important, pool fund, to be able to assemble pool fund to take care of those people that will not be able to access the care. But again, we must be getting good quality care as well. So that's why we have to raise the accountability bar, and the legislature has the role to play. They are doing oversight. They do accountability. We should try as much as possible to leverage some of these legislative instruments as well to get the best for our healthcare.
All right, Dr. Gafar Lawode, expert in health finance, and I'd like to appreciate you and thank you for your closing remarks. Let me also appreciate first our guest who joined us via Zoom, Dr. Ibrahim Wada, Chief Consultant Gynecologist, Founder and Chairman, Nhir Hospital, and also Chief Executive, Garki Hospital, Abuja, a public-private partnership with the Federal Capital Territory. I need to emphasize that. Dr. Ibrahim Wada, always a pleasure to have you with us. And Honorable Dr. Yusuf Tanko Sonono, Chairman, House Committee on Health Care Services, and of course, former Secretary General, NME, member, Presidential Committee on Health Sector Reforms. Thank you for coming. All right, let's join our foreign desk as we'll trail developments there.
Tigray People's Liberation Front spokesperson Getachew Reda said Ethiopian army alongside allied forces from the northern Amara region began the attack to push Tigrayan forces out of Amara. The new offensive has shattered a ceasefire that Ethiopia's government declared in June as its forces retreated from Tigray, where it had begun pursuing the Tigray leaders who had dominated the national government for 27 years before Abiy took office and sidelined them. Thousands of people have been killed since the political dispute turned deadly in November last year. Meanwhile, millions of teenage girls across Afghanistan still await to return to school, while the Taliban allowed boys to attend classes. The move has raised concerns about the future of female education under the Taliban, who have pledged to uphold the rights of girls and women in the country when they took over power in August. The exclusion of girls at this time has aggravated fears that the Taliban could be returning to their hardline rule of the 1990s. During that time, women and girls were legally barred from education and employment. In his address, the UN Secretary General Antonio Guterres also urged the international community to inject liquidity into the Afghan economy to avoid collapse.
All right, so that's it on Good Morning Nigeria today. Thank you for tuning in. The program returns tomorrow, same time, 7 in the morning. Look after yourselves. I'm Kingsley Osadolo.
And of course, join us in the fight against rape and rapists, and do continue to wear your face masks, and of course, wash your hands. COVID-19 is real. I am Claire Adelabo Abdul Razak from all the production crew. Have a wonderful day.